So you have a choice of radiation quality. What does that mean? Well, you have a choice of which energy you use. So if you have two machines, for example, one is 6 and 10, one is 6 and 15. What would you use the higher dose, higher energy for? Just the little thing is called a stereotat. So you attach the needle to that, and the other ones are just substitutions. So if you have two machines, that one is a 10, 6 and a 10, one is a 6 and a 15, and you're treating a rather large lady with the carcinoma of cervix, which energy might you use? Higher one. Unless, of course, you're doing IMRT, then all bets are off. So, but usually the bigger the patient, the higher the energy. Entry points. So here we have, I'm presuming this is supposed to be the same as this. So this is the X-ray, this is the plan. So we're doing, so what kind of configuration is this? Four-field box. I was waiting on you saying that. Yeah. So it's a four-field box. So AP, PA, and 2 laterals. And unfortunately, this is being cut off. So the colors that you see, this is, I guess this is the light blue, which I think is 102%. This one is red, and I think that's 100. This one is green, and it's 95. And then you have this little one, and it is, let me see, I think it's 85. And the lighter ones, the orange is 50. So you can see the distance, and this is the PTV. So this would be it, and of course that is on one slice. And this is of course the other, this is an X-ray, an AP X-ray. So it's a different area, it's the same area that's shown in a different way. So we have number of beams, we have entry points. That's where your tattoos come in. Are the tattoos always the same as your treatment entry points? Why not? Excuse me, should talk with my finger mother. Why not?
No, it's not.
Okay, so can anybody answer that one for us? Why are the tattoos not necessarily the same as the treatment entry points?
There's first setup.
Pardon?
Their first setup.
Which are the
Tattoos are for setup.
tattoos are for setup.
Patient
okay.
setup.
Okay. And so how do you tell which are tattoos and which are setup points and which are treatment entry points?
Where we
By
are
the
is
notes.
different colors.
Okay. So which are which?
Blue is CT.
Thank you.
Green is treatment.
Okay. And if you have a boost, is that a different color also?
Have you noticed?
What was the question?
If you have a boost, is it a different color?
I know in second
Like
ISO
the
is black.
markers.
Mhm. Yeah, so that's one department.
When you're treating a patient.
So you do the tattoos where? Normally,
NCT.
where do people put on the tattoos?
NCT.
The CT?
Yes.
Everybody? CT for tattoos? UF does, they don't use tattoos, do they?
In Jacksonville,
But Gainesville does?
Yeah.
Yeah, okay. Yeah. You think they would go, but they don't, so, anyway, so, tattoos are done in CT. Unless you're really, really good or really, really lucky,
Funky.
your tattoos very, very seldom match where the isocenter is. It's maybe only half a centimeter out, but they're usually different from the treatment entry points. So what do we do with the treatment entry points? Do we go with the tattoos? And for those of us who do tattoos, do we position with the tattoos and then shift to treatment? Or do we put marks on the treatment centers?
Marks.
Marks on, yeah. So you now have tattoos and treatment centers. And you ask the patient very kindly not to push the marks up. Do they listen? Sometimes.
It doesn't look good.
Okay,
Smell good.
so entry points, number of beams. This depends entirely on dosimetry. The physician usually has no input into the number of fields patient has. There's usually a technique that is used. So if it's a breast, for example, there's usually 2 fields. But if you're doing IMRT prostate or IMRT cervix, there could be a multitude of fields. Or a multitude of beams. Same with field sizes. If you're doing 3D, you will have field sizes, right? If you're doing, for example, a 4-field box, this is 3D. You would have field sizes. The AP and PA might be something like a 10 by 12. The laterals could be something like an 8 by 12. Or a 10 by 10, or an 8 by 8, or whatever it happens to be. And then the MLC would shape them. But with what we're doing with IMRT and VMAT, you don't really use field sizes, do we? What do we position them to? If you're setting up an IMRT patient, you're setting her up, setting him or her up supine. Do you have, obviously you're using lasers, but do you have a field beam for the AP? How do you position on the AP? You set up with the laterals, right, with the lasers. How do you set up the AP? Anybody? How do you set up an AP field if you've no field light? Do you have a field light? Do you have a particular field size that you set up with the field light? Yes, no, maybe, don't know? Never noticed? So how do you set up with the field light, without the field light then, or with a field light? What field size do you use? What size is the light beam that you use to set up the AP field? You're doing a 3-point setup, am I right? Okay. So the question stands, how do you set up the AP? How many times have you set up for your patient? Lots of times, right? How do you set up a 3-point setup if you have no field light on the AP?
The lasers?
Which laser do you use? The sagittal laser. So how do you know if soup to inf is correct? Because all you have in the sagittal laser is a line, right?
I'm trying to remember, Jacksonville does the 2 APs. I know in Gainesville, they would have 2 anterior marks, so you could line them both up.
2 anterior marks. Okay,
Up
so
here,
that would be
that's-
lining them up this way.
One would be here, and then one would be lower.
Yeah, but it's still, you still have to have a way to align it this way.
Those are the 2 laterals.
Two laterals can be off. If you have a patient that the sides are mobile, then the laterals don't necessarily mean that they're correct. Or at least the soup to inf part. The add to post is probably correct, but the soup to inf may not be. So how do you set up the AP? What other laser do you have? Pardon? Transverse, where does that come from?
Axial. Split the body this way.
But I'm saying, where does the laser come from? The roof. So you'd have to move the gantry out of the way, right? To get your cross.
Oh, I see what your question is now.
I
Yeah.
Yeah.
thought that was the AP laser.
That is the AP laser. You're talking about the sagittal, you were talking about the sagittal laser.
See,
The
and I just
sagittal laser
asked
only
this-
goes one way.
I just asked this the other day, is have we gone over all the proper names for the different lasers? Because somebody mentioned that in clinic the other day, and I'm like, I don't actually know all the proper names for the
Yeah.
different lasers.
So you have the lateral lasers, which are inside the thing. You have the sagittal laser, which is usually up on an angle here, and it gives you one line going straight down the middle. Or down this way, anyway, it doesn't have to be in the middle, it can be over here somewhere, but it gives you a lateral. And then your AP laser, which comes from the roof, but you have to move the gantry out of the way to see that laser.
Now, does the AP one line up exactly with the sagittal one?
Yes,
Okay.
at isocenter.
I never noticed.
Yeah, at isocenter. So, that's one way to do it without a light beam. But again, if you're setting up, you should not rely for setup on your cone beam CT. You should be able to accurately position your patient with the lasers and the marks before you even think about doing a cone beam CT. Does that make sense? Okay. Okay. So, we've positioned our patient. And another question stands, what do we use field sizes if you're positioning for an IMRT VMAT, do we use field sizes? Yes? No? No, we don't need to, because there really isn't any field size. Once you start the VMAT, it automatically changes field sizes all the time, basically, so, yeah. So blocks. Shielding. We'll ignore blocks. Shielding. For 3D, we still can use MLC, right? For this one. If there was shielding there, we'd use MLC. Very rarely do we use blocks anymore. For photons anyway. For electrons, that's a different matter. We have to use blocks. Wedges. For 3D, do we use wedges? Yes. Either physical or electronic wedges. If you don't have electronic wedges, then you use physical wedges. Compensators. We don't use them much anymore. They're not used anymore. Simply because we've got IMRT and compensators we don't need to use those. But we'll get into that in a little bit. So beam number and weighting. So remember we went over weighting last week and my simple question was a 2-to-1 APPA chest. So here's a little bit more of a real world one. So here is one beam, 100% to that one beam, to the target. Here's two beams, 50% each. That's 1-to-1 weighting. Here's another one. So this is 40% AP, 30% this way lateral, 20% PA, and 10% this way lateral. Simply because of where this is placed. This would be 3D. With IMRT, it gets really complicated. But this is 3D. So you have 10% of the hole coming from this angle, 30% of the hole coming from this, 40% coming from here, and 20% coming from here. So weighting of the beam as to how much they contribute to the dose at target. Weighting of the beam as to how much dose is incident on the patient. These are not the same. So weighting the beam as to how much they contribute to the dose at the target. So this one, I guess, is the weighting of the beam. They contribute to the target dose, which is what we really need. We're not worried about the other one, that's the symmetry. So we worry about this one. So 30%, 40%, 10%, and 20%. Incident dose is what? I don't think we've actually gone over what incident dose is. What's another name for incident dose? You've maybe heard it called given dose. It's the dose that is given to the patient that comes out of the beam. So the incident dose in this case would be 25, 25, 25, 25. So the weighting of the beam is the dose to the target or the isocenter. That's what dosimetry has to do. Decide how much dose comes from each beam. Wedges. Wedge pair and a 3-field. So you notice that the wedge pair, we'll call it an AP and a lateral. What type of treatment might we use this type of treatment for? What type of tumor might we use this type of treatment for? We're coming from an angle this way, an angle this way. Anybody? Take a guess. If you're wrong, that's fine. Somebody else is obviously thinking the same thing, so.
First.
Rest. No. It's a wedge. It could be a tangent pair, not a wedge pair for the breast. Okay, so which treatment area might that work? What?
Pelvis.
Okay. Why might we use an AP and a lateral on a pelvis? Yeah, because that's what that is. It's an AP and a lateral. You just throw it out there. Okay. So if we were treating the the sinuses, maxillary sinus, which is right here, correct? You wanted to treat that. That would be ideal for that, because you'd be treating AP and a lateral. So you'd only be treating this side of the field, this side of the body. Does that make sense? That is your archetypical AP wedge pair. This one. It could also be, since some nice kind of person cleaned the board for me, I'm going to muck it up again. So, if we did this, and the tumor is here, right? Then we could treat a plan here and one here. Okay. So which way would the wedges be?
Lateral will be healed.
See again?
The lateral would have to heal the top.
Heel at the top. Okay. Or thick end at the top, okay? An AP,
To the right. Or my right.
this way,
The other way.
the other way,
Heel.
okay. That way? Okay. That's your archetypical. You can see it here. So the rule of thumb, ladies and gentlemen, you have to remember this, is 99.99999 times out of 100. If you're using two wedges like that, the heels or the thick ends would be together. So this one, your thick ends are together. This one too. So here is your three field technique. So we've got two laterals and an AP. You notice where the wedges are. Thick ends, anterior. Why?
Is it because of overlap from the AP dose?
No, it's not actually. Good God, but it's because of the slope here. See this slope? So if I do something like this, and I put a wedge field here and a field here, then your thick ends of your wedge would be here. Because of the slope here. The wedge is actually filling in the air gaps, if you like. The lack of tissue here and here. If you have a slope, then you have to put a wedge in. If you're doing 3D. If you're doing IMRT, that's another matter. Okay? And your thick end again, the same way. You wouldn't put an AP wedge in because you'd have to have it both ways. Let me ask you another one. So, if you have, this is a chest patient, and you're doing an AP field and a PA field. Let me just move this a bit. Okay, you need to put a wedge in the AP. If you think about you lying down, you have this slope from here down to your neck. Which way would a wedge go if you had to use a wedge? This is AP, this is P, this is superior, inferior. So thick end where?
On the surface?
It's on the AP side, yeah, which way is it?
Superior side.
Superior, yep. Okay, so you have a wedge going this way because of the slope. So this is a different plane. Normally your wedges are going this way or this way. This way you're going down this way because of the slope coming up. I'm not even sure, I can't remember what this, whether there's something like that on the way here. Let's see, okay. So a 2D approach. So entry point, field size, blocks, wedges, compensators. They're basically the same. Entry point is the same, field size, depending on what we're going to treat, wedges and compensators. Okay. So, multiple beams, dynamic delivery, non-coplanar, dose compensation, IMRT, just non-missing tissue, and biological planning. So, multiple beams with IMRT. How many beams do you have? A normal IMRT prostate, for example, VMAT. How many beams do you have? It depends, doesn't it? It varies. Well, how many arcs do you have? There's usually 2 or 3 arcs, right? Sometimes 2, sometimes 3, sometimes 4. How many beams? Lots. Each. If you start on VMAT and you start at an arc, it's basically continually moving. Your IMRT is moving in and out, your field size is moving in and out. You really can't see or tell how many beams you actually have because each of these beams are beamlets. So really you can't tell. Dynamic delivery. What does that mean? That means that you're moving and your MLC is moving in and out. The only one that wouldn't be dynamic is your step and shoot. So dynamic would mean that you're rotating, or you're not rotating, but your MLC is moving all the time, your field sizes are moving all the time, and if you're using VMAT, then your fields are moving all the time. That would be a dynamic. Non-coplanar. What does that mean? Non-coplanar.
Not on the same field.
Pardon? Not on the same plane. So what does that mean then, not on the same plane? Give me an example of a non-coplanar field. I'll give you one. So, let's use Fred. Okay, Fred. We're going to treat Fred's head. Normally, you would treat this way, correct? Or this way. So it's usually this way. Because he's lying. Do this way. So Fred's lying down. So you'd be treating this way, right? Or is it this way? It's this way. So Fred's lying down. You're going to do a VMAT. We're going to rotate around this way or this way, right? But the doctor wants to treat a field, a vertex field. What do we mean by a vertex field? This way. So that would be a non-coplanar field because the planar is around in this direction. That's your plane of treatment. If you treated a vertex, you'd have to come in this direction. How do you do that? We did it upstairs last semester. How do you do that? Couch kick,
Yeah,
so couch kick of how much? 90 degrees, so Fred would either have to turn on the bed this way or this way, and the gantry would have to move. Okay, that's what we mean by non-coplanar.
we've actually got somebody like that.
You do?
Well, that we're treating the top of their head. I've never seen it until now, until it's finished.
So what are we treating?
And I'm not really sure, but I do know that they have like, because I've only seen it once, because I took lunch at a different time that day, so I didn't see it.
Mm-hmm.
And the top of the mask is like cut out, and they put bullets on the top.
Ah, yes,
So I don't know what they're doing.
yeah. Is it electrons, do you know?
No.
Okay.
Well, I think, well, I don't think so.
Okay, so sometimes the non-coplanar fields are usually pituitary, where they're treating straight in, so you're treating two fields like this and then a field in like this. Sometimes it could also be that they're treating electrons and it's a skin tumor on the top of the skull.
I need to look and see, because I
Yeah.
can't remember. I only saw it one time.
No, that's fine.
We had one that was nasopharynx that way, vertex.
So they treated the vertex or
They did both.
nasopharynx?
They did both, like you had just done.
Right,
Yeah.
for a vertex, for a nasopharynx vertex? Okay. That's unusual. Okay, so non-coplanar, that's what it means, okay? So dose compensation IMRT, not just for missing tissue. So IMRT, because it can use little beamlets to alter the intensity of the beam, we don't really need compensation. So if we have a field like this, for example, we can do a VMAT through the chest and not have to worry about putting a wedge in, because the IMRT plan will substitute for that. And that's the beauty sometimes of an IMRT plan. Biological planning. What the heck does that mean? Biological planning. Anybody get any ideas what that means? Radiobiology of various tissues. We all know that the spine has a cutoff of 4,500. Each tissue is either radiosensitive or radioresistant, which means if it's radioresistant, you can give a large dose. If it's radiosensitive, like for example, the lens of the eye, or the kidneys, or the testes, they are very much radiosensitive. So you have to be extremely careful what you do in that vicinity. So if you're treating the orbit, the sinus, especially the maxillary sinus, which is the most common, you have to be extremely careful about the lens of the eye. If, however, it is growing into the orbit, which it sometimes does, you may have to treat the eye, but you can save the lens. You can protect the lens. If we're treating the abdomen, what's the thing that we have to protect? What areas do we have to protect? In the whole abdomen, what areas do we have to protect?
Kidneys.
The kidneys, because they are extremely radiosensitive. You can only give the kidney approximately 2,000 before you start causing problems. So you have to be extremely careful.
What's the limit for the lens of the eye?
The lens, I think, is something akin to 800, but I'd have to look that up. It's very, very sensitive. And actually, it's sometimes as simple as asking the patient to look straight up. So you're lying down, patient's lying down, and if you just ask them to look straight ahead, or pick a point, you're lying on your flat on your back, you pick a point in the ceiling, and you can finagle the lens so that it doesn't get any treatment or variable treatment. So target localization. Reference images. What do diagnostic procedure CT scan? Okay. Reference images, what do we use for reference images when we're treating patients? DRRs. Where did DRR come from? DRRs, where do they come from?
Dosimetry.
CT. Yeah, CT, they come from CT and dosimetry makes them from CT, yeah. So they actually come from a CT, not from, they come from dosimetry via CT. There's a simulator image, so we don't want that. Film. Okay, machine data requirements for treatment planning. So beam description, quality, and energy. So we give, the dosimetrist needs is a 6 MV that we want to do, or the doctor wants to do, or a 15, or a 12, or a 10, whatever it happens to be. Beam geography. Where's the isocenter? Where's the table? When you're doing a CT, and you see the images coming from CT, the slices coming from CT, you'll notice that the table is always in the image, because dosimetry, to do a plan, needs to know where the table is, so that they can tell where the posterior edge of the field is. And what gantry angles you need, but that's usually done in dosimetry itself. So field definition, source, the collimator distance, the applicators, the collimators, the blocks, the MLC. So it wants to know which machine you're doing this on. Which machine you're treating on. If you want one machine, then that's it. But if you're in a large center where you have multiple machines, how many machines does Gainesville have?
6.
6. So if you are in Gainesville and you have 6 machines and they're all doing different things, dosimetry needs to know which machine this patient has to be on, or they may leave it up to dosimetry which machine they go on. For those of you who have been in dosimetry, have been in Gainesville, I can't remember, it's been a while since I've talked to them down there. Do they specialize in each machine? Is each machine specialized?
2 is mostly head and neck.
Yeah, so one machine is usually head and neck, one machine pelvis, one machine breast.
4 gets a little bit of everything.
4 gets everything.
Well, there's always one.
Well,
that
and
gets a
then
little bit of
six-
everything.
Gets
6
a large
can't
variety.
get like gynos, so GYNs.
We get a lot of breasts.
Yeah, so
Yeah.
there's usually, if you have a large number of machines,
6 has a lot of
one
prostate.
machine sometimes does breast, one machine does head and necks, one machine does pelvises, and there's usually one that does a little bit of everything.
I don't know what one never did. Did they just do a little bit of everything?
They
I
do a
guess
little bit of
so.
everything.
We never heard anything about one.
4 was down last week and I had to go work with one for like 4 hours. It's everything. It's,
Yeah, so it might be that if it's a breast, it goes into this machine. If it's a pelvis, it goes onto that machine. If it's a head and neck, it goes to this machine. If it's something weird like a spine or something else, then it goes to any machine that has a place for it. So, applicators. So if you're doing electrons, what size of electrons do you have? Normally, what size of electron applicators do you have on a machine? It depends slightly on whether it's an electa or a variant. So, anybody know what size of electron applicators they have?
I think in Gainesville on 4, it went anywhere from 4 to 20.
Yeah, but in between, which electron applicators did you have?
4, 6, 10, 14, 20.
Okay. And in most variant machines, it's 6, 10, 15, 20, 25. And if you're using a 25 cone, make sure you have 2 of you to put it on, because it really. Okay, so collimators and blocks are MLCs. So obviously, most people these days use MLC, unless it's electrons, then you use the serpent cutouts. Physical beam modifiers, wedges and compensators. I don't think anybody uses physical wedges anymore, except for Sanford. Compensators aren't used at all except on protons. Dynamic beam modifiers, dynamic wedges, arcs, and MLC IMRTs. So everybody knows that there are IMRT, dynamic wedges, what is arcs, MLCs. MLCs are planned in dosimetry. If the doctor wants to alter the MLC, which means he's altering the wedges, it goes back to dosimetry. You never ever do it on the machine. It has to go back to dosimetry because it means that the plan has to be redone. Again, this is, okay. Oh, there we go. Who is responsible for preparation of beam data for the planning process? Who is responsible for the preparation of beam data for the planning process? It could be the symmetrist. It could be CT therapist. It could be partly CT therapist, partly physician, or it could be a mixture of all three. Depends on what the protocol is in the department. Acquisition of beam data. We'll do this later on this semester, towards the end. So this is, has anybody ever seen one of these?
The route version of it.
I've seen it, but I haven't seen him use it.
You know what it's called?
Water bath.
So water bath, yeah. So water bath. And normally you would see the physicists wandering around with it. It's usually empty to get it into the treatment machine. So yeah, what that does is, it is, you see the ionization chambers here, here, and there's usually some tucked in here somewhere. And what happens is that this is all attached to a piece of equipment outside of the room, and when the machine starts, it gives it actually produces isodose tables or depths. So you want to know what the depth, the percentage depth dose is at 10 centimeters. You run a beam, program it, and it'll give you the percentage depth dose at 10 centimeters. So water phantom, ion chambers, film phantoms, and documentation, obviously. So this is done usually in the evenings, overnight, or on weekends. So unless the machine is actually down for maintenance, you probably wouldn't see this done. But any chance you get to, if a physicist is doing something like this, please ask him if you can go in and observe, because you don't see it very often. Okay, isodose charts, hard copies, we don't usually have hard copies anymore. Isodose charts, output factors, tables, wedge factors for emergency and computer breakdowns. Computers do break down, surprisingly as it seems. Although we would usually use them for emergencies, there's usually books of these charts that are in usually dosimetry for backups. And if you are coming in to treat an emergency patient, this is what you might use, are these charts, so you can do hand calculations. Oh, and there's usually a computer program that will walk you through. It's called, one of them I know is called an MU check. And it will give you the data that you need to find the monitor units for the dose that you want to give. An independent checking device, which is, just as I say, MU checked, should be completely independent of data set of data. So you have all these, anybody been into dosimetry? Or at least walked through or seen it? You'll find that, how many computers are in there? Many. So you've got all these computers in dosimetry. And this MU check computer program has to be separate from all the rest of them, so that the therapist can actually come in on a weekend and work on this MU check computer without touching any of the dosimetrist's babies, which are the computers, because they don't like people who aren't dosimetrists to touch their babies. So we have particular MU check computer usually that we can come in and do a hand calc for a weekend treatment. Data must be dated, verified in regular intervals, and the source, including the person responsible for it, must be documented. Everything has to be up to date. There's no good doing, sometimes it's very bad to actually treat or use the data sets if they're not up to date. That's when errors happen, and sometimes very bad errors. As you can probably see, this is not an English-speaking person who's doing this. So, need to include all beams and options. Collision protection, physical limitations. This is why dosimetrists tend to be radiation therapists first, because they need to know what the machine can do, and more importantly, what the machine cannot do. if you have a patient on the bed and you're doing a planar feel, a rotation this way, but they also want a coplanar arc this way, what happens when the machine comes up on here and goes dunk and it hits the patient? If you're not a therapist and you've got a Bachelor of Science degree and they've trained you to be a dosimetrist, you don't necessarily know that the machine won't do that. Or will do it, but it'll kill the patient in the process. So you don't necessarily know that that won't work. The same thing applies if you have this beautiful plan, and I think I mentioned this story, if you have a plan that is 2 or 3 millimeters away from the spinal cord, and is a beautiful plan, but it's not clinically correct. And why not? Because you have a patient on the bed and he's breathing. And if it's 2 millimeters away from the cord and the patient breathes, what happens? We treat the cord. This is some things that you have to be aware of. Collision, again, this fancy one, but even if you're doing a normal arc, do the therapists do a check rotation before they start a new patient who's an arc? So they'll go in, they'll position the bed, and they'll make sure that the machine clears. Good. And that's why they should do it, because they're not. They also want to make sure that the cone beam CT, when the arms are out, it doesn't hit the patient or the machine. That's why we have a collision alarm. And we have to do a check. Physical limitations, just as I mentioned. So data can be made available for planning in installments as required. I think what they mean by that is that if we are doing a patient and Dosimetry has planned part 1, so you're doing part 1 and then they're in the process of planning part 2, and then you do part 2 and then there's the process of planning part 3, that would be what they meant by installments. Why is that a good thing or a bad thing, do you think? Treating part 1 while they're planning part 2.
Maybe we need to see how the patient responds to treatment.
Okay.
Plan the second half.
So you want them to finish part 1 before they start part 2? Before they start
I mean, maybe
planning part
not
2?
finish, you probably have a good idea halfway through, but maybe finish, I don't know, it's.
The problem is that in most cases, the full effect of a treatment course is not seen until 2 or 3 weeks after the course is finished. So you'd have to, in that scenario, you would have to wait 3 weeks before you started part 2.
We've had breast
Which is not-
patients that they canceled the second half because they were getting bad skin reactions.
Oh, yeah.
Like halfway through the
Yeah.
first part.
So that's fine, but that's a skin reaction, that's not the tumor underneath. Skin reactions are something totally different as far as what we're talking about. So what's the problem with everything's planned at once? So part 1, part 2, part 3. They're all in your treatment plan. You've got part 1, you've got a plan part 2, and you've got a plan part 3. Is there any problem with doing that? The only thing you have to be careful of when you're doing that is you have to make sure that you're extremely careful that you cannot physically start part 2 until you finish part 1. So dosimetry has to make sure that there is some kind of barrier from starting part 2 until you finish part 1. That makes sense? Because you don't want to, oh, we'll just start part 2 now, because you haven't finished part 1. Unless they go in and say, okay, we finished part 1, doctor says cancel, start part 2. So some data may be required for individual patients only. Special treatments. That might be stereotactic. It might be whole body. It might be half body, might be some whole body electrons, that type of thing. So that would be for very much an individual patient. Only make available data which is verified, and that's where dosimetry again comes in. You have to make sure if you are doing a plan or you're checking a plan, which you have to do on the treatment machine before it starts, make sure everything is verified. So you don't start a plan which is not verified. And that includes signatures from everybody involved. The dosimetrist, the physicist, the doctor. And don't take a phone call saying, yeah, I'm okay with it, you can go ahead and continue. No. That is not acceptable. He can't phone down from wherever he happens to be and say, yeah, I agree with that, go ahead and treat. No, that is not acceptable. Because what happens? He comes down and I didn't tell you to do that. Yes, you did. So if he did do that and insisted that you start, what is your option? Is there an option for you? Is there an option? The only option you have if they insist, you put a note in the treatment sheet saying, Dr. So-and-so gave a verbal okay to continue with the plan. Sign it, date it. And the next time the doctor, you see the physician, say, I need you to sign this. Otherwise, I'm not treating it again tomorrow. And you're right within your rights to do that, by the way. Well, you're not, but the therapist is. They're quite within their rights because that's not really good enough. Data is wedges for what data is available for physical wedges in your center? Well, most people, there is no data. We don't use physical wedges. Wedge angle, wedge output factor. Field sizes, wedge be used. Yeah. Field sizes for the wedges are always lower. As you go up from 15 to the wedges, the physical wedges are 15, 30, 45, 60. Those are the 4 wedges. The 15 wedge can be used up to, I think, 25 by 25. 30 and 45 can be used to an 18 by 18, I think. And the 60-degree wedge, your maximum field size is a 15. So if you're using physical wedges, you have to be aware that you can only use certain field sizes. And it will tell you, if you try and put 15-degree wedge in the one, and you have a larger field size, it usually tells you. Okay. Been waiting. I think maybe we'll stop there. And I'll send us the rest of the